Hello and welcome to Coproduce Care. That was a little bit of a preview of our guest tonight, but I just want to say hello to everybody who is new to us. Coproduce Care is an organisation that was started at the end of last year, and the whole aim is to open up the health and social care debate. And anyone who does know us or is used to us or has watched our videos before, we have been blogging and vlogging about social care for a while now, since the end of last year. And we've reached out to a lot of people to see if they would come on and talk to us about what's going on in social care, and how we can have a bit more of an in-depth discussion about what's happening and what we need to do differently, and how we need to maybe challenge what's being done to support the sector at the moment. And I'm really delighted today to have Roy Lilley with us, who will introduce himself in a moment, but safe to say we have interviewed him before, and Roy doesn't hold back. He will tell you what he thinks, and it's usually extremely interesting. So, but before we get going, just a reminder that if you're watching on YouTube or on Facebook, then please like on Facebook, and if you're on YouTube, then subscribe to our channel, because we've got some amazing speakers, including Roy, of course, speaking tonight. So get involved with supporting us that way. That's the best thing you can do. Our services are absolutely free. We're doing a lot of work with volunteers in the background to get things going. And all we want is for more people to hear from the fantastic guests we have. So without further ado, that's my interest in intro done. One other thing is that we want lots of people to hear about Roy, and to hear what he has to say. But we can't do that unless people share and get their friends and colleagues to come on and have a look at what we're saying tonight. So yes, welcome, Roy.
Hello,
Roy.
Sophie, and hello everybody watching.
Hello. Well, thank you so much for coming on today. I think it would be great if you told people a little bit about who you are and what you're doing. I know I've interviewed you before, so I know that you've got the fab NHS Stuff Academy, and that you've got an amazing resume. But if you could just, for anyone who doesn't know you, could give us a bit of an intro.
Right. Well, I'm a professional has-been. I used to be a businessman. I started my first business at 16, and I've always run businesses ever since, and I'm 75 now, so I've never had a proper job. I've never had an interview for a job, and I've never passed an exam. So that's me. As well as that, I've been the chairman of a district health authority, and if anybody's old enough watching tonight, a district health authority is on the way back. They're called accountable care organisations, but that's fundamentally they manage the whole of the health economy. I was the chairman of an NHS trust. I helped start the Health Services Management School at Nottingham University. I've been a visiting fellow at Imperial College. I've written 27 books on healthcare and healthcare management. I run something called NHS Managers, which is a daily or pretty much daily e-letter that goes out to readers, about 300,000 in a week. I also started the Academy of Fabulous Stuff, which is a repository of best practice in the health service. I'm one of the owners of the Institute of Health Management, and I'm also have a company called UK Health Gateway, where I help startup companies get traction for mainly innovative digital style products in the health service. Also, I appear on telly and Sky and what have you as a sort of talking head and commentator. So I think that's me. I'm a professional has-been.
Yeah, I love that. No, but you're not. You're a has-been and is going to be. I mean,
I'm a was-been.
You're a was-been. I'm interested because I'm involved in social care more than I am in health. So I'm interested to know what are the issues that you're hearing about through your network with the COVID-19 outbreak and crisis. I mean, we've got the usual headlines, but are there things that are happening that aren't normally put on sort of, legacy media?
Well, I tell you what I heard today, which is interesting, and I'm not sure it's in the mainstream media yet, but trusts have been stopped from buying PPE themselves, and they have to buy it now centrally. And that sort of tells me that we're going back to some kind of rationing arrangement. We don't have to recite the whole of the PPE problems again because we know, what they are. But I'm just wondering whether or not there is a shortage. As far as social care is concerned, I think the big news is that there have been more deaths amongst social care workers than there have been NHS workers during the whole of this COVID, this dreadful COVID thing. So, I mean, that's really quite that was a surprise, I must say, to me. And then, of course, there's the perennial discussion that's sort of still lurking around is what is the future of the relationship between health and social care? Will what we've gone through with COVID and the huge debts that are accumulating now across local government and the health service, because I mean, people, the NHS can just pretty much spend what it wants at the moment. The Treasury is standing behind it, and I guess it's the same for local government. What will happen to social care? Will this drive some kind of merger in the NHS? I mean, it is pretty clear, isn't it, that the operational gap between healthcare and social care frankly, it's a damn nuisance. And wherever, in management speak, wherever you get two organizations, you get healthcare and you get social care, and wherever they meet, the meeting bit in the middle is called managers call it an interface. And wherever you get an interface, you get the potential for things to go wrong, miscommunications, budget responsibilities dragged from one side to the other. Just language issues and management responsibilities. So, if we could get rid of that interface bit in the middle, I think that would probably be a good thing. Because then we have to ask ourselves, well, why haven't we done it? It looks, such a no-brainer. But I think it's because, of course, social care is in the purview of local government, and social care is means tested. Healthcare, of course, is a standalone organisation and is free at the point of need. So if you put the two together, do you make social care entirely free? Or do you start saying, well, actually, bits of healthcare will have to be means tested to match the means tested in social care? So, I mean, there's a big, political, philosophical argument to be had about what the future of those two organizations might be. And I don't think that that's an argument that's ever been properly settled. And the final thing I think with social care is that do you remember when New Labour, you're too young to remember this, Sophie, but when New Labour got elected.
Very kind of you to say that.
Yeah, they were elected in, what was it, 97, I think it was, and Tony Blair arrived in Downing Street with this things can only get better and all the rest of it. And he appointed Frank Dobson, who was the Secretary of State for Health, really very unexpectedly. No one expected Frank to get a big job like that, but he was a very committed guy, and he was, very for socialised healthcare. And I remember him promising that he would sort out the mess between health and social care. And he would publish a green paper just as soon as he could. And we've been waiting for a green paper on the future of adult social care since 1997. And subsequent governments have been saying, where's we'll do a green paper. And I remember.
I didn't know that. I didn't know it went back that far. I thought the green paper was all about what the government has talked about recently.
Yeah, it does. And I interviewed Matt Hancock, the present Secretary of State for Health, 2 years ago. And I said to him, well, where's this green paper you're going to write on the future? He said, it's coming soon. I said, well, when? How soon? And I really pressed him. And he said, well, April. And I said, well, that's good. Because what I omitted to ask him was April which year? Because we still don't have it. And of course, with the COVID thing now, and with the Brexit thing, I mean, we've all kind of taken our eye off the ball as far as Brexit is concerned, but that's going to occupy a huge amount of bandwidth in government, as well as trying to recover from COVID. So I can't see this government producing a green paper on the future of adult social care this time of the next election. We're looking, 5 years away. So, you know what? I think it's back in the long grass.
Yeah. I was really interested to hear about what you said about the PPE issue, because I don't feel like it's been talked about a little bit this week. Last week it was quite strong, but it's really bad for hospitals, and then you stretch out to people in the community. It gets worse and worse and worse, and you just don't know where the end is, really.
Well,
but also,
Sophie, I tell you, it's going to get worse, and I tell you why. Because as we very gently try and get back to work, there'll be people like bus drivers, train drivers, people on the tubes. They'll all want a mask. Now, I know government is saying, "Oh, you've got to have a face covering." Well, people are going to try and buy masks, aren't they? And that's going to do two things. First of all, it's going to dilute the market, and secondly, it's going to put prices up, because people making them are going to say, "Well, we can add a few quid to the cost of a mask." So all of that pressure, and it's not, estate agents are opening up today. It was announced today. Well, estate agents going into people's houses, they're going to put on a mask. So there's going to be the returnees to work who are going to want PPE. I imagine schools are going to want some, and it's not just masks, it's visors and, whatever people do. So I think it's going to put extra pressure on trying to find manufacturers of not only face masks, but gloves as well, because people are going to wear gloves, and I know there's a epidemiological argument about whether you should wear them or wash your hands or wear a mask or just keep your distance, but people are going to do it, aren't they? And so on top of that, the NHS is still trying to buy PPE, and then care homes, there's more money going into care homes tonight at the number 10 press conference tonight. It was announced, and I think it's another 600 million or something going into care homes, which is about clinical governance and infection control. That's going to involve more PPE. So there's a huge demand on it. And of course, we're not the only people in the world that want PPE. Right across Europe, there's care homes that have got the same problems that we've got. I was reading an article in one of the European papers earlier this week, and if you read about Germany, France, and Italy, and all of them have got the same care home problems, because care homes are care homes. They're not nursing homes, and they're not geared up to look after people in these sort of circumstances. So it's going to put more pressure. And of course, guess what? The factories that make all this stuff are in the Far East. And guess what? They've got people who've been off sick because why? Well, they've got COVID-19. So there's been a downturn in production, an upsurge in demand. And it looks to me like this is going to kind of happen again. I hope it won't, and I hope I'm wrong, but I wouldn't bet I'm wrong. I think I probably am half right, at least, that there's going to be another crescendo of demand for PPE, and we're just not geared up to do it yet.
What do you think about easing the lockdown restrictions? Because some people say, well, it's great that people can go and semi kind of visit family, kind of not. And then other people say, well, actually, it's going to increase the likelihood of a spike, and the people who are going to suffer are older people who have been dying again. Is there something that we should be asking for or doing now which will prevent another surge of deaths? Or do you think it's just going to be inevitable? And if you keep the lockdown, people are going to just not follow it anyway?
Yeah, look, the answer to this question is really blunt. And, I want to couch it with all the caveats I can, insofar as I absolutely get the damage that CV-19 COVID virus has done to families and loved ones up and down the country. And, we're getting to the point where almost none of us really don't know somebody who's either had it or sadly died from it. And I'm not ever trying to say that we shouldn't recognize that, and we shouldn't continue to do everything we can to protect people. But, and this is the blunt bit, the fact of the matter is, we simply do have to find a way to get Britain back to work.
Yeah.
Because we're going to go broke. I mean, the amount of debt that we're racking up in the Treasury. Now, we're lucky at the moment in that interest rates are low and the government can still borrow. And, you know, they call it sovereign debt, the government borrowing, but that won't go on forever because other countries are doing it. France is doing it, Italy's doing it, everybody's trying to borrow.
Yeah.
And we're going to rack up a huge debt and we're going to spend, I mean, I will be, in my lifetime, I will never see the end of the COVID debt. And that's going to be austerity, and it's going to be tax increases, and it's going to be God knows what it's going to be, printing money, inflation, you know, I mean, the whole of that economic scenario is pretty bad. So we have got to get Britain back to work. How do we do that? Well, I mean, locking down Britain was easy. You just pass a law and say, everybody stop doing everything. Job done. It was easy. Getting Britain back to work in this interconnected world that we're in now. You can't open a school without impacting mums at the gates, caretakers, suppliers, the workers, people going back to work, families, grannies. You know, you can't, everybody's joined up with everybody else. So you can't do one bit of the economy without it impacting somewhere else. And as this is a transmission virus, if you increase the opportunity for transmission, like we've seen today, today we're recording this, and this morning there was films on the TV of the tubes in London jam-packed, and I bet wherever you're watching this, you'll have the same stories of people on the trains and the roads and all the rest of it. And so we are inviting transmission. If you invite transmission, then guess what? The graph's going to go back up. And if the graph goes back up, the government have to come in, they're going to close things down again. Now, I think that it's a risk that we're going to have to run to see how much we can open up before admissions to hospital start to be, you know, pronounced, and we have to say, whoa, stop. And this is really tricky balancing act, because what the government's announced over the last couple of days is really not very much more than we've been allowed to do already. I mean, people have been able to run businesses and open up their businesses since the beginning, if they can do it safely. But of course they can't. Social distancing makes it really impossible for most businesses to operate normally. So, you know, when you say, should we be locked down? Should we get out of lockdown? We've got to do it sooner or later. Germany's done it. They're ahead of us. And already their R number, their reproduction number, R0 has gone up, it's gone over 1, which everybody says, well, that's bad. And they're thinking about, because the federal, people don't understand that, or maybe they don't understand that Germany's a federation of 16 federated states, and they're all independent, a bit like the United States. And a lot of those states want to open up. And Angela Merkel has been saying, whoa, hold on. But she was outvoted. They've started to open up, and already they've got a spike. So, this is a risk. It's a terrible thing to say, but this is the adult thing to say here. It's a risk that we're going to have to take very, very cautiously. The Prime Minister talked about baby steps, but, even baby steps are too big. We have to be really cautious how we do this, but we just somehow or other have to trickle back to work to get the economy up and running and people's jobs and get some money in their pockets. I mean, at the moment we're paying, 60% of the workforce, we're paying 80% of their wages. We can't do that. No country in the world can do that.
It's a fine balancing act, but I suppose for me, I always think, will the next generation, how will they view us when either there are a lot more deaths or, the economy is in such a state for them going forward? It is a fine balancing act. I mean, your immediate, I think, reaction, emotion is to think, well, life has to come first. And that's always the point that I come from. But then I do understand, with the economy, then there's going to be other injustices or other suffering because people don't have money to live. But I suppose in terms of protecting care homes, it's really welcome that they're going to get more money. I haven't actually seen that yet, but that is welcome, because if you are going to open up, you're just going to have to support the community services a lot more.
Yes, I mean, care is really, just to go back over some of the issues on care homes. I mean, why has it gone wrong? Well, the clue's in the title. They're care homes. They're not nursing homes. And so they didn't know how to do this kind of infection control. They didn't know how to do barrier nursing because they're not nurses. Care homes are run by two sorts of people. You got the small care home run by an ex-nurse, maybe a social services person, maybe runs 2 or 3 in a small group, and then you get the big ones that run, several thousand care homes. But they are set up to care. They're not set up to nurse people with a rampant virus going through the place. And when we decanted people out of the NHS. That's how we cleared 33,000 beds. That's how we did it. We just got the frail elderly, who were fundamentally the people that we were having difficulties getting into care homes with all the normal stuff. We just decanted them. Now, we did it, and it was free. So none of the relatives complained, and none of the elderly people complained, because they were thinking, I'm going to a care home, at least I'm getting out of hospital. But of course, they were decanted. No one tested them to figure out if they got any infection or not. And they weren't tested because at the time, we didn't have enough testing capacity. So we put untested, frail people into care homes being looked after by well-intentioned people who just didn't have the skills. And on top of that, they didn't have reserves of PPE. They didn't have a cupboard full of gowns and masks and gloves, because they just don't have that kind of stuff. And none of them in their resilience planning had any of those reserved. So it was a disaster waiting to happen. And now, what are we going to do? Where are they going to spend this money? Well, if I was going to spend the money, I'd spend it on educating the staff. I'd get them really tooled up so they understood about infection control and how, if the infection has spread, it can only have spread because all of the elderly people, as far as I understand, they're in their rooms in the care homes. If the infection spread, it's been spread by the staff. Now, they haven't done it deliberately, and they're not stupid, but it's been spread predominantly by the staff. Either staff have caught it outside and brought it in, or they've been asymptomatic and we haven't tested the staff, so we haven't known.
The only thing I would say, obviously, operating a couple of care homes myself, is that actually I've been really, really impressed with how much the care home managers have really stepped up to the plate, despite not doing nursing. The main issue that I found is that right at the beginning, which people are more aware of now, is people, care homes being asked to take people without testing. There was no, we had to take really difficult decisions to say we really can't take people back, because a lot of care homes did the lockdown before the lockdown, and they said we can't have people back. And that was really difficult because local authorities and hospitals were really uncomfortable with us doing that, saying, well, you're putting a strain on the NHS, when we actually now know that we're under pressure, and actually care homes suffer more because they don't have the clinical staff. No,
they don't. They absolutely don't. There was a guy on the television the other night, a care home proprietor, and he refused to take people from hospital. And apparently he came under enormous pressure, and he took a lot of stick, but he said, I won't do it.
Yeah.
And guess what? He hasn't had any COVID problems. He's had problems, but he hasn't had any infections like the rest of them have. He said no. And of course, if the care home industry had a more cohesive trade representation, and they got together and they had aligned their intent and said to government, we are not going to do this until you test everybody, then government would have had to have produced more testing. So
that's a really interesting point, because I've been thinking about that recently. The fact that with the NHS, they do seem to have a lot of power, and there are trade or associations that are talking to government.
Yeah, NHS providers, the Confederation, I mean, the organisation I run, the Institute of Health Managers, we have very strong voices. But the problem with care homes is it's either the big five, HC1 and Bupa and what the others, I can't remember, but there are five big ones. And the rest are small to medium-sized enterprises with a few thousand beds, in each one. And the industry, it needs consolidation, what we in business would call consolidation. There are too many small providers and they can't get the gearing right to make it work. I mean, look at the fees that they charge. But they charge local authority clients, I don't know, 385 quid a week or something, which is like a pitiful amount of money. But private clients who can pay, they're charging £1,200. In some cases, I had a woman write to me. She said she was paying £2,500 a week for her mum to be in this care home. It's a very nice care home. But she said next door, in the next room, there's someone from the local authority and they're paying £700. And she said, I'm subsidising the local government, and that can't be right. We need, if anything comes out of this, Sophie, it's got to be a proper sort out of care homes. I think we've got to stop the difference between nursing and care homes. And I wouldn't license a care home unless it had a full-time nursing complement, full-time, a prescribing nurse full-time. And, that's going to put the costs up. But hey, we can't go through this again.
Yeah, I mean, I'm not sure I agree 100% with that, but what I would say, which is fine, we're all good but what I would
cry.
Yeah. But what I would say in that is, so some care homes have said, well, local GPs are just not going in, so we've been abandoned. So if you did have someone with clinical expertise there, they may be able to kickstart.
But they've just started paying GPs now. They're saying you have to do this as part of the primary care network arrangements. That was part of what they called the DEL, the way they get paid. They were going to have to do it, and the GP said, we can't do it. We don't have enough resource to do it. Now they're going to make the GPs do it, and it won't be part of the PCN DEL or the contract. And they're just saying you have to organise to provide a medical presence in your local care homes. Right. Now, I don't really know, what the upshot of that's going to be. But we can't. You see, when you put someone in a care home, they go in with an acuity level, and they go into because they can't really quite look after themselves. They go in to be with people of their own age and interests, and the rest of it. They go in, they get their decent food, a bit of help to take their medicines, and sing the White Cliffs of Dover and have fairy tea cakes, and someone comes in and sings to them at Christmas. That's care homes, and it's fine. I'm no complaint about that. But of course, they're not in there for long before their acuity drops off. And they start needing a bit more care and a bit more care. Before you know it, they've crossed the boundary of care into nursing care. And really, the expectation is they will move from a care home to a nursing home. But they don't. And they don't because if you move to a nursing care, the NHS has to pay. If they're in a care home, the individual has to pay, or it's means tested by the local authority.
So you've got these pockets of money, and it becomes political then. It gets less kind of, which is why I think a lot of people don't understand, even I don't understand all of it, how complex the social care landscape is. And even when it starts to be a little bit more collaboration between the two, there's going to be so much to unpick. Okay, so I wanted to move on to the other news story. There's so many. COVID has unearthed a lot of skeletons, I think. The issue with non-white people a bit and how they are affected, and of course, there's so much news about the NHS in particular being supported by a lot of non-white groups and really high death rates. And I was on a call. I don't know what your thoughts are about this. and one MP discussed about having a official inquiry into treatment of non-white groups and COVID. What do you think about that?
Well, look, there's an inquiry going on, isn't there, at the moment? The ONS have produced the data. It's pretty clear that there's a problem, and nobody really sort of understands there's a problem. And we'll have to see what the upshot of the inquiry is. And I don't know why it's taken as long as it is, but the Public Health England are doing it, I think. And I don't know, they probably got a lot of other things to do as well. But this, for me, would be a priority. Look, we don't really understand this. Now, it may well be that in the broader context of this, BAME workers, a lot of them are in what we call low-skilled work. It's a very ugly phrase, low-skilled work, because at the moment we're starting to see that all these people that are doing patient-facing, customer-facing work, we need their skills. But that's the sort of shorthand that people use. And because they're low paid, the inference is that their housing isn't very good, that they're living in overcrowded housing circumstances, they're still out and about, their exposure to the viral load is higher than it would be for a managerial class. And maybe that's right. And if it is right, there are things that we need to do to fix it. But maybe that's right. But then on top of that, you've got the data from the NHS, where BAME colleagues are nurses. And I mean, nurses will say they need to be paid more money, but I mean, they aren't poorly paid. And we got doctors who certainly aren't poorly paid, although, everybody says give them more money. I get that. And so those two prospective reasons don't mesh. So that can't be right.
Yeah.
It can't be universally right. Let's put it that way. Then on top of that, you've got issues around genomics and all the complexity that, and I have no idea why we're in this situation, but we need to fix this, because in the NHS, which is something I know more about than being a bus driver or working on the tube, we have a huge reliance on BME colleagues. And you and I have discussed before, in my view, I mean, I think we treat our colleagues in these circumstances very badly often. And the lack of seniority, the lack of promotion, lack of opportunity, the lack of representation on boards is all something that the NHS should be ashamed of. And people, are trying to do some stuff about this. But where we are and where we are at the moment is, what do you do? Well, I was on a television program recently and we were talking about this, and they said, well, Roy, what would you do? And I said, well, if you want to stop this happening, you have to move all your BME frontline clinical staff away from the front line and move them into non-COVID exposure work. Can we do that? Have we got sufficient alternative staff to fill the rotas? And the answer to that is, I don't think we have. I don't think we can actually do that. And so we are in a really difficult problem. All we can do is we can say to BME colleagues, look, if you're not comfortable working in this environment, we'll try and get you to work somewhere else. We can be absolutely sure that the PPE that they've got fits properly and works properly, and they've got enough of it. But other than that, in the circumstances that we're in, you either move everybody out or you try and make them as safe as you can in the working environment that we've got. But this is a hugely difficult problem. It's operationally, if I was still running a trust, I would certainly look to see if it would be possible to move people out of the front line if that was what they wanted. And frankly, even if it wasn't and we could do it, I think I'd try and do it, because we just don't have the answers. I have no idea what Public Health England are going to say.
Yeah, I'm interested to see what they say, because we were talking about it on some other calls. We were thinking, well, do we have specific, and I think we should, risk assessments for those groups, and what would they
so the interesting thing about that is, I mean, you could say, well, let's do a risk assessment, but we don't really know what the risk is. We know there's a risk that's demonstrated in the statistics, but we can't do a root cause analysis to do a risk assessment, because we don't know the root cause, and we won't know the root cause until Public Health England sort themselves out. So if you do a risk analysis, you know, all the managers will tell you do a root cause analysis, risk analysis, and then you got your plan to sort it out. We can't do the basics. We don't do enough testing, for example. I mean, we don't test. I mean, we're just testing people who think they might have a virus. Really, we should be testing every member of staff every 3 days. And that way we can find out. Until we get testing sorted out, and it's a mess. I mean, I've read today that there's a black hole in the testing that's being carried out by these windswept car parks run by Boots in the private sector. It's not just Boots, but there are others as well. The private sector results have gone somewhere or other, and no one knows where the data is. God. So God knows what's happened there. But it's a colossal mess. So we need to be able to do testing. We need a root cause analysis. Then we can do a risk assessment. All we can do at the moment is to say there's a risk. We don't know what it is, and we will remove you from that risk. But then you get to the situation is, can we do it? We've got such a dependency on BAME colleagues who are at risk, we know, and we don't understand why.
Yeah, well, this is what I was going to come on to. You know, we don't know what the risk is. We can't have the root cause. Well, we know it's COVID, but like you say, you know, we can't pinpoint. But do we just say, you know, I think the statistics say among Black men, that's really high cohort. Do we then say, you know, like what you're saying, we'll have to shield you, or we'll have to do something because you're, you know, depending on what your work is, we'll have to put you in different positions that keep you more protected, or you will have priority in PPE. I'm wondering whether that's a line we go down, and if we don't, why wouldn't we? What's the justification?
Well, listen, I don't know. I know a lot of guys that and women that run trusts, you know, and I know them at senior level, and I don't know any of them that wants to avoid a responsibility like this, and all of them are looking at it. All of them are talking to their colleagues, and all of them are trying to limit the risk. But we can't eliminate the risk because we don't have enough people. I mean, what we've forgotten about in all this, you know, COVID panic is we've forgotten that we're 40,000 nurses short. Before all this started, we didn't have enough nurses. Before all this started, we didn't have enough staff working in care homes. Before all this started, we didn't have enough doctors. And so it's easy to forget that we're starting from a very, very low base. And as I say, I don't know anyone who wants to put colleagues at risk. But it's a real difficult problem. And the quicker Public Health England pull their finger out and get us a report, the quicker we can start doing things about it.
I was just wondering, do we put too much, you might know this more than me, Public Health England, there was someone from the SAGE, the Independent SAGE, I think it's called, the new SAGE that has been
Scientific Advisory Group, yeah.
Yeah, but not the one that the government uses. There's another one.
This is the new parallel SAGE with
right.
Alison Pollock and all the that lot, yeah.
So someone there was saying that actually Public Health England hasn't got the resources to do what it needs to do because of historically how it was set up, and there are only a few in each area. And, you know, I don't know whether we've got the right systems, and whether, you know, like what you were saying about risk assessments, we just need to rethink how we do everything rather than saying it needs to be Public Health England. Maybe there just needs to be some kind of joined up thinking with NHS England and everybody else.
Well, let's try. I mean, let me try and give you a quick primer on the way we are with Public Health England. Public health used to be part of the NHS. As a result of the Lansley reforms of the health service in 2012, they were taken out, lock, stock and barrel, as an arm's length body, the operational arm of public health became Public Health England, and they were parked not in the health service, but in local government. And the money that came with them was not ring-fenced. Mm-hmm. So some local authorities, not all, but some local authorities used some of the money for general treasury demand, not just for Public Health England. We now have a great sprawling central organisation, Public Health England, that's responsible from, on one hand, Porton Down and nuclear accidents and Russian spies coming here and poisoning people on the streets of Salisbury, through to pork sausages in Sainsbury's and will they give us salmonella? It's a huge sprawling organisation that I think is too big to run. I've said so. I would break it up. I would also put public health back into the NHS, where I think it most comfortably fits. But as far as the funding is concerned, the funding followed the new marriage between Public Health England and local authorities, but it wasn't ring-fenced, and a lot of public health money went into general treasury demand. And the public health community in local government has never been expanded on. Now, they are responsible for doing track and tracing, and they do it in measles and diphtheria and all that kind of stuff. And they're very clever at it, but there's not enough of them, which is why we've recruited, or we're trying to recruit, 18,000 keen volunteers to try and teach them how to do track and tracing, which is not easy. And then on top of that, of course, we got the new app, which is being trialled at the moment in the Isle of Wight. So that's the kind of background and the risks that I see with public health.
Yeah. In terms of, I feel like it's always so doom and gloom. But on the bright side,
I mean, there's loads of good news. I mean, I run the Academy of Fabulous Staff, and it's the director of the Academy is Dr. Terry Porritt. She's terrific, full of enthusiasm. And she curates the what we call shares. That's where people share their best practice and new ideas. And we're running something at the moment called No Going Back, where we're saying, listen, the trust have said we changed something and it's so good we're not going to go back. And there's loads of stuff that's being done around technology. Doctors are starting to do consultations on FaceTime and Skype and kind of things that we're doing now. I mean, normally we'd have this conversation with you and I in the same room, but we're using technology. And this is very good. Maybe we won't ever do another one without doing this kind of thing. And so there are a lot of workarounds and innovations that have been undertaken in secondary and in primary care and in social care, to the huge benefit of the patients. I mean, look at outpatients, for example. Normal outpatients, you get an appointment, it's inconvenient, you have to take half a day off work, drive there, go in a car park, it costs you 10 quid to park your car, you sit in a corridor, wait there, things are always late, you go in there, you're there for 3 minutes and they kick you out. Why can't you do that on Skype or what we're doing now, whatever technology we're using here? Why can't we do that? Well, the answer is we can, and we are. And I tell you what, I've seen more changes in technology in the last 30 days in the NHS than I've seen in the last 30 years that I've been around the NHS. I've been around for a lot longer than 30 years, but for 30 years I've been trying to get the NHS to wake up to technology, and it's all happened in the last 30 days.
What was the because I remember months ago when I was about a year, 18 months ago, I just learned about Microsoft Teams, for example. Super excited, really interested in doing it. And yet I would try and get a local authority to team up with me to say, can we just support care homes to adopt this because we think it's really good. And it's just like tumbleweed. And then overnight, suddenly it's all, and with these things are easy to do because it's just click a button and it's done.
Yeah. But I can tell you, in Liverpool, Liverpool and other places, the problem with it was that care homes, for example, we're talking about care homes don't have access to NHS email addresses, and because they don't have NHS email addresses, they can't connect inside the protected IT environment of the NHS. The NHS protects its environment very fiercely because it doesn't want to be hacked and all that. It'd be a disaster if the NHS got hacked. Remember WannaCry and all the palaver there was around WannaCry. Well, up in Liverpool, they actually gave a couple of care homes NHS email addresses and an iPad. And when the care home residents felt a bit off or there was a problem, they'd FaceTime some nurses. There were 3 nurses working 24/7, and they were prescribing nurses, and they used to do consultations on the iPad. And the nurses would say, well, what's your temperature and whatever. The staff, they did this protocol thing, so the care home staff knew what to do. And they said, I think you need an antibiotic or whatever. They prescribe it, e-prescribing it. Or they'd say, well, I think you'd better have a visit from a nurse or a visit from a GP. They cut care home admissions into the NHS by are you ready for this? Ready?
Yeah, go for it.
60%. 60%.
Wow.
It was amazing. And now, of course, everybody's doing it. So, there's and we help pioneer that on the Academy of Fabulous Stuff because it's just up our street. It's the sort of thing we love doing. So there's a lot of innovation. There are good things to come out of this human disaster.
Yeah. And you hear about, one of the good things obviously is that we're talking more about health and social care. We're getting these discussions away from the, conferences in London or boardrooms, and we're just having a public discussion. We're doing things like this, and it's on the TV a lot. So I think that will help galvanize the movement towards how do we support the sectors in different ways, and how do we do things differently and more collaboratively. So I think that's a good thing. And also just the lovely things that you hear that communities are doing. We really want to there's an organization called Can Do in Bristol, and there's the National Food Service as well, and they're doing amazing things with delivering food to people who are shielding, and it's just fantastic, some of the other things that are happening. So yeah, it's just capturing those and making sure we don't lose them when things do get better.
I absolutely agree. And there was a paper that was leaked yesterday. I had a copy and I published it yesterday, where they're looking at how the NHS will be organised in London. And if it goes the way I think it is, it'll be a good thing because it'll start getting people to work together more. The secret to this is working together. And we come back to the care home thing. I mean, where the care homes have worked well is where the NHS has sent in infection control nurses to train the staff and tell them what to do. And that's one of the reasons why the infections in care homes is coming down, is because the NHS has woken up finally to the fact that the care homes can't cope with this by themselves and they need some help. If we had a closer working relationship, that probably would have been done way before the COVID thing showed up. We should be doing it anyway.
Yeah, absolutely. Good. Okay. Well, I don't think we have huge amounts of questions. People have just been commenting.
No, I've just been looking on the edge of my screen here to see what people are saying. They've made a
few comments, but if anyone does have any questions for Roy, then do pop them in before we close off.
There's an interesting one here about the illegally invalid PPE being sold. I mean, that was a bit of a disaster when we bought all that stuff from Turkey, and it turned out we bought a pup. I don't know how the hell that happened. I mean, somebody that was bought by I have to say, it wasn't bought by the NHS. It was bought by the Department of Health. So the NHS isn't guilty with that. But I think what a lot of people don't understand is that the PPE itself that's used in high viral loading environments, that means in hospital and care homes for that matter, has to pass quite stringent tests. And we've had a lot of face masks that don't pass what's called a vapor penetration test, where the virus molecule can pass through the mask and so on. So it is a very high level of testing and approval that's required. It's not unique to here. It's a European standard, and that's why it's been so difficult to get proper stuff.
Yeah. One other question I wanted to ask you, and it's a question that you're going to hopefully answer with a question, is that we heard recently that tomorrow night we're going to have the Minister for Care join us on a chat. And I just wanted some ideas from you. What kind of questions do you think we should be asking?
I think I would. I mean, it's mainly care homes, isn't it? And I think I'd ask a direct one-line questions. I'd say, why did you send a lot of frail elderly people out of hospital into care homes without testing them. Why did you do that? And if the answer is anything but we didn't have enough testing capacity, then she's frankly telling porkies, because I think that's really important. The next question I'd ask her is, we've seen the very fragile environment that social care is in. When are we going to get the green paper on adult social care? Because we know Matt Hancock said it's ready. It's in the final stages of ready. And I know from what I've been told from the inside that they had a good idea was going. There's no reason to delay that. That consultation is urgent. So when are they going to do that? And she'll probably try and fob you off. But I would pursue those two questions.
Yeah, okay, that's a good one, and that's a plug, therefore, for everybody else who's joining in. If you do want to ask some questions, obviously that would be great, and you must also join us tomorrow at 7 o'clock, and you can plug some questions into the comments box, Roy, and prompt me to ask any questions. I'm
not popular enough in government. I think I'll keep well out of it.
That's fine. You know, I've got 20 minutes. I've got from 7 o'clock till 7:20. And, you know, I just want to get as many questions as possible, because it's amazing that a minister does want to talk directly to people who are in social care, not through mainstream media, but just directly to people who can answer questions from comments. I think that's really refreshing. So we just got to make sure that we do get our experiences or our questions out there. And it's been great sort of talking to you tonight to really think about some of those issues in a bit more depth. So, Roy, I think we've had our time.
Looks like time's up. I'm just looking at the clock in the corner of my screen. I think we're out of time.
Yeah, we're getting there. Yeah, thank you so much for joining us. And
can I just say, it's a great opportunity to have a good old gossip about things, you know, that you're not in a hurry. I mean, if I do a slot on Sky or the BBC, I know that if I got 3 minutes at the outside, I mean, quite often you get 90 seconds. So I'm very pleased to have the opportunity. And I think you're doing a great job with getting people in and talking to them and, you know, really getting to the heart of stuff. So well done, Sophie. And I wish you great success. I think you're doing a great job.
And you know what? We might even have you back again. There's no reason why we wouldn't. Let's see how we are in a few weeks, months' time. And
it's certainly very easy. I can sit on my sofa and pronounce from the comfort of my own home. Yeah.
There you go. So thank you so much. And if people want to follow you, I had your that's your Twitter there at Roy Lilley, and the website there for Fab NHS stuff. And I think that's a great organisation.
Yes, please have a look at the Academy of Fabulous Stuff. Link on campaigns, and then you can link on coronavirus and no going back. And they're the two things that probably people will be most interested in at the moment. Please.
Yeah. Wonderful. I really appreciate that. And if anyone does want to be kept up to date with what we're doing in terms of our live streams, then if you're on YouTube, you can just hit subscribe and click on the bell, and that just gives you a notification when we go live, so you won't miss anything. But of course, all this is recorded as well, so you can listen back. Okay, then. Well, thank you so much, Roy. It's great to have you on, and hopefully see you again soon.
Thank you all. Keep well, keep safe, keep washing your hands.
Good one to end on. Thank you. Bye, everyone.